contents of my presentation are as follows: the history of breast surgery, indication of total mastectomy, types of mastectomy, and timing and type of reconstruction surgery. It's interesting to note that the history of breast cancer dates back a very long time. In 3000 BC, Egyptian physicians described breast cancer in papyrus records. It was actually very precise, and there was a lot of information related to breast cancer. So in ancient Greek times, Hippocrates also mentioned about breast cancer, about what kind of symptoms you can notice. And he mentioned that it is caused by imbalances of humors. So as a doctor, a modern-day doctor, I'm not able to understand what he actually tried to mention here. But anyway, he mentioned that this is one of the diseases that is caused by those types of situations. And in the beginning of the Middle Ages, Christians thought surgery was barbaric, and therefore everyone just focused on prayer in order to overcome the disease. During the Renaissance era, there's rapid growing knowledge about the human anatomy, and the surgery was actually started. However, the problem, of course, is that there was no anesthesia. So surgeons had to be very fast and very accurate. I don't know what this disease was, but as you can see, there's no anesthesia. People are grabbing the patient down onto the chair. And the caliber of surgeons, how good a surgeon was decided by the speed of which he could go ahead with this type of surgery. Look at the tools that were used for surgery. It's almost like woodcraft-related tools. Do you know what this is? This round tool that you see here in the picture? Can you imagine? Yes, it's what you imagine. These were the tools and instruments used for breast cancer surgery. There was no anesthesia, so tools were used to make things go very fast. It's very brutal, as you can see. It's not like you can identify breast cancer at early stages. It's only when the disease has progressed to a later degree that it was identified, and therefore they simply just got rid of it. Of course, major developments were made in the 19th century, so surgical anesthesia was adopted. However, in 1867, there was a major development and advancement as the antiseptic medicine was introduced. I know that Professor Kim mentioned earlier, but it is with William Halsted that we see the actual modern breast cancer surgery develop with the radical mastectomy. And as you mentioned earlier, it was indeed a radical mastectomy because they took out the skin area as well as many of the muscles surrounding the breast. This may seem quite barbaric and brutal. However, you have to understand that back then, people came in for breast cancer diagnosis and treatment only when it was this late. And of course, there were very harmful side effects because of that. This doctor was the person who developed alternative treatments outside of radical mastectomy. So modified mastectomy was introduced. And since then, of course, the degree of side effects was decreased, and there was not much difference in terms of disease-free survival or other types of overall survival. And so this became the standard of modern-day breast surgery. So radical mastectomy, simple mastectomy, and breast conservation surgery. These three types of surgery have become the norm or the standard these days. Of course, It would be nice to have breast conservation surgery. However, there are some contraindications. First of all, you have to go ahead with a radical or a total mastectomy in cases where the tumor size is large in relation to breast size, such as in the case that I showed you earlier with the radio image, with the image that you saw earlier. Also, if you have, for example, diffuse suspicious microcalcification on mammography, it does not mean the same thing, but it does seem more possible that they have come with similar causes and roots. So in these cases with multicentric disease, then if there's one or two or more primary tumors, then instead of doing surgery on these different locations, you have to go ahead with mastectomy. Another contraindication of breast conserving surgery is, for example, in an area where you have to really look at the overall situations, such as inflammatory breast cancer or history previously to therapeutic radiation, or if you're pregnant. So this anatomically is how the mastectomy will be conducted. So dissections are created in the skin, and then you leave the fat, but you take out all of the breast tissue. You can definitely see the border area right away, and that's how you would go ahead with the surgery. Even if the scar is not too visible, the fact that your breast is no longer there, that is a very sad fact. And it does cause a lot of psychological issues. And even in daily life, physically, it is quite uncomfortable. So that's why breast reconstruction came to be. This is something that may be reconstructed later or immediately during the surgery. As you're well aware, reconstruction was finally started to be reimbursed 50% by the National Reinsurance System from 2015. I know that many of you were involved in the efforts to make this possible. Many people actually went out onto the streets to let people know about the situation. So fortunately, we are receiving 50% reimbursement for this operation, and I would really like to extend my sincere gratitude to all of you survivors and patients for your active efforts. Prophylactic and contralateral mastectomy and reconstruction with BRCA mutation patients is also covered from 2017. Once again, thanks to your efforts. These days, if possible, we go ahead with immediate reconstruction. That is to say, reconstruction at the same time as the breast surgery. However, the size and the shape will have to be created like this during the reconstruction surgery. Of course, depending on each case, the dissection line and the direction in the area may be different. In some cases, it's near the nipple, some cases not, or underneath the breast. You may make use of implants or autologous tissue transplant. Both can also be conducted. This is nipple-sparing mastectomy. So this means that this patient had the cancer tumor near the nipple and therefore had to go in this direction. Many of you would prefer reconstruction, and many of you would like to maintain your own nipple. However, in some cases, that is not possible. For example, if the cancer is severe, if it's inflammatory breast cancer, then there is a high risk of recurrence. It's not to say that the surgery will make it more probable that there is recurrence, but there is a high risk of recurrence fundamentally. So from that perspective, after a couple of years, then there may be a recurrence. So we would wait a few years before going ahead with the reconstruction surgery. I mean, you cannot try to spare the nipple with the risk of having cancer spread, so you wouldn't want to do that. So this is such a case. 3-4 years after the surgery, after the treatment has been completed and she's in relapse, then we went ahead with the reconstruction at that point in time. There are many types or techniques of surgery that can be adopted. There is breast conserving surgery, there's total mastectomy, and even within mastectomy, there's simple mastectomy, nipple sparing, or skin sparing. And in reconstruction, you can go ahead with immediate or delayed, depending on the situation, and you can use implants or autologous tissue. So there's no one truth. There is no one silver bullet for everybody. It also is dependent on the patient's situation, the disease conditions, and there are many different several options for operation method depending on those conditions. For cosmetic reasons, both for the patient as well as for the clinician, of course, you want to go ahead with something that has the best outcome. However, safety or being disease-free is the highest priority. It's the first goal of surgery, to cure cancer. Therefore, everything will be decided upon with in-depth consultation with your doctor. All decisions will be made after that. Since I'm in charge of our survivors, I really know that you are going ahead with your meetings despite the fact that it's COVID pandemic era, so you have to meet on Zoom. You can't meet face to face. I saw the cooking sessions, the Nanta percussion concerts online. That's wonderful. Let's, stick it out a bit longer. I know that it's hard. And the chairman of our society is attending these sessions as well. After the pandemic, we'll go see the flowers. We'll get together. We'll meet each other. Until then, I sincerely hope that you'll stay safe and healthy. Thank you for your attention.